On. We are live now.
Good evening, everyone. Welcome to the platform of Orthopedic Research and Education Foundation India. Today we have our chairman, Dr. John Mukhopadhaya, sir, who is teaching us about Pilon fracture. So over to you, sir.
Thank you, Janki, and welcome to today's webinar. I'll just start with sharing my screen, and today we are going to discuss Pilon fractures. This is a fracture which has multiple problems in its treatment, and just like the proximal tibial fractures, the soft tissue injury forms an important part of its management. So, for example, this is the sort of situation you would be dealing with. This is a 46-year-old man who comes 3 days after his injury. He's got no other injuries, no comorbidities. And this is the kind of fracture. And you can imagine that there'll be a lot of swelling and maybe blisters or skin issues that will be along with it. And we'll come to this case later. But basically, if one looks at the learning outcomes of today's talks, I think the most important part is to appreciate the soft tissue injury in pilon fractures. Once you come to surgical management, it's important to identify the key fragments and the areas that you need to reduce. You have to look at the deforming forces which you need to buttress against, and then you need to execute a plan of management and then perform your surgery accordingly. So there's a whole host of different types of fractures. The spectrum of the fracture is huge. It usually involves the distal tibia with or without a fibular fracture. There's usually intra-articular involvement, but what is probably the most important part is of these pilon fractures, or the characteristic part of these pilon fractures, is metaphyseal involvement and impaction or comminution of this area of the metaphysis. So the most important lesson that we've learned in the last 2 decades or so is that the soft tissue injury really should dictate your plan of management. Otherwise, you will end up with disasters such as this. Now, if one looks at the evolution of treatment of pilon fractures over the years, I think if we looked before the 60s, one really treated these with apathy, in that you felt that these fractures did badly whatever you did. Then you came to the honeymoon period in the 60s and 70s, when Rudy and Algauer published their work and were doing these on fractures, which was mostly in skiers in Switzerland, and they were able to report excellent results with operative treatment. However, once you came to the more high energy fractures in the 80s, you started getting multiple papers showing the bad results or the disasters of early operation, and as well as problems with the soft tissue. And so in the 90s, the move was away from open reduction of these fractures to external fixators, and even on to definitive external fixators for management. And then you came to this period of reconciliation. That was that you initially managed these with spanning fixator to wait for the soft tissue to settle down, and then do a staged open reduction and internal fixation. There was also, over a period of time, a role for minimally invasive surgery for some of these fractures, which was suitable for it, not for all pilon fractures. So I think if you looked at the results, as I mentioned, in the 70s, Rudy and Algauer came with their excellent results. But following it, you saw papers from various people showing disastrous results in high energy pilon fractures. And similarly, subsequent papers showing that open reduction, internal fixation, especially early open reduction and internal fixation, worked well on low energy fractures, but failed when used for more severe pilon fractures. Now, the classification that Rudy and Algauer suggested was again based on X-rays, which you had the minimally displaced fractures And then you had the grade 2 types, which were displaced fractures, and then the grade 3, the fractures with displacement and comminution. And although this was useful for the period of time that where fractures were basically managed with based on X-rays only, the OTA classification, which was based on the Rudy classification, as well as the classical extra-articular and intra-articular types, divided them into 43A, B, and C, depending on whether they were extra-articular, partial articular, or complete articular. So here, even the very distal tibial fractures, which did not have articular involvement, were included in the Pilon fracture group. Now, there were various studies to look at the reliability of the Rudy and Alcover classification, and these studies really showed poor observer agreement in the various of the classification, and they found that it was not necessarily a very useful research tool. And as time went by and you started doing CT, you realized that the CT was very important in identification of the fracture pattern and comminution. The identification of major fragments, especially the anterolateral tilo fracture or the posterior Volkmann's fragment, as well as details of the medial malleolar and the articular die punch injury, were obviously better picked up on the CT. And Tuneta in his studies showed that CT added additional information in 82% of the cases and actually changed the surgical plan in 64% of the cases. So it became more and more apparent that CT was becoming a more almost a necessary tool in the management and understanding of these fractures. So in 2005, Topless from the UK came out with this CT-based classification where they described that there could be 6 typical fragments. You had the anterior fragment, the posterior fragment, the medial, the anterolateral, the posterolateral, and the die punch fragment. So if you looked at these figures, you have the anterior fragment here, the medial fragment here, the posterior fragment here. You also had the anterolateral fragment, which could be a part of the anterior fragment, the posterolateral, which could be a part of the overall posterior fragment or a separate fragment. And you had a die punch, which was in the center where the articular surface was punched in. So they also divided these into 3 main groups: the coronal group, which formed the bulk of it, which was 56%, the sagittal group, which was 33%, and this was really based on the mechanism of injury, and a third group where there was severe comminution, where it was really difficult to assign it to either the coronal or the sagittal group. So these were the kind of fractures. You had the lower energy fractures, which were relatively minimally displaced and less comminuted, and the high energy fractures, which were more comminuted, and different families of the fractures depending on it. So the Topless classification was a little better in terms of the inter-observer and intra-observer reproductibility. And so it was a slightly more reliable classification in terms of research and inter-observer and intra-observer reliability than the Rudy and Alcover classification. Similarly, there were other CT-based classifications which have come into the literature, and you need to go through these to figure out which is most useful for you. The staged protocol and the 4-column concept has been described in this paper from China by Yu Chen et al., which really looks at these 4 columns: the lateral, which is the fibula, the anterior, the medial, and the posterior column, and how you need to buttress these columns when you are dealing with these fractures. And Peter Cole et al. Came out with this Pilon fracture map, which was like looking at the forces and the fracture lines in a whole lot of these patients and then trying to analyze which are the areas which were most often involved. And they found that the anterior, the lateral, and the medial part of the extending more posteriorly were really the most common areas which were involved in these pilon fractures. There was another study which looked at how well modern plates were able to capture these fragments. And this was useful to really understand where your screws would go, but it did not really tell you where you needed to put your buttress plates, etc. Okay, so when you deal with these fractures, what you have to deal with is the initial X-ray, the soft tissue management, and usually the soft tissue management involves putting on an external fixator. However, if the swelling is not significant, you could wait and wait, sort of either in a low energy, you could go directly to surgery, or where there's not gross displacement, you could wait with a plaster slab. But in most of the really displaced fractures, the whole idea is to first put them on a fixator, then do your CT scan, and then plan your management. So the so-called span, scan, and plan, again, very similar to what you do with proximal tibial fractures. So here's this patient again. This was the X-ray. It was put on a spanning fixator. Okay, so those are the CT scans done after the fixator has been put on. You can see the various reconstructions. There's the coronal, the sagittal reconstructions, the 3D reconstruction, and then the axial reconstructions. And what is important is to identify the key fragments. So if you look at all these fragments, this anterolateral fragment is the one that's most grossly displaced and the one that you need to reduce. And then you need to decide where you can buttress these fractures. And so you have to decide your approach. There's also a fibular fracture, which you need to deal with in this case. So based on that, we decided to approach it with a lateral approach. Now, this is a relatively new approach. There have been two descriptions of this, one by Gross et al. In GOT in 2007, where the incision is along the anterior border of the fibula, and a second one by Femino and Vecinen in the Iowa Medical Journal in 2011, which has the incision a little more posteriorly, almost along the posterior border, and then curving towards the base of the fourth metatarsal. What is claimed in this paper is that this is more along the lines of the angiosomes and dermosomes in terms of the skin and nerve supply of this area, and therefore they feel that it is less likely to slough off if you do it along this line. So that's what we did here. You can see the incision. And the first thing is to go down to below the deep fascia onto the sort of periosteum, but not into the periosteum. So you need to dissect extra periosteally, and you gradually take out all the tissue from the fibula, including the peroneus tertius, across to the medial side. Okay, so you go on to the fracture, you can visualize the talus. So here you can, once you open the joint, you can look at the talus, the articular fragments. And usually before we fix the fibula, we would try to clear this out, see if there's a problem with length or how much comminution there is, and sometimes even get a provisional reduction of the articular surface before we go down to the fibula. We would get the fibula reduced, and in this case, since it was not a very comminuted fracture, you need to get this out to length, get it reduced anatomically, and then we fix that with a plate. So once the fibula is fixed, we can then go on and deal with the tibial fracture. One of the advantages of this incision is that you can visualize the superficial peroneal nerve quite high in this approach, and where it is less variable in its distribution. So when you come lower down, sometimes you can damage the superficial peroneal nerve. Here you're more likely to be able to identify it clearly. Okay, so then you go down, you get the articular surface reduced. So you can see the talus here, the articular part of the distal tibia being reduced accurately here, provisionally fixed with the K-wire. And then you go ahead and do your final fixation. And here we use this anterolateral plate. And here, because we were able to get multiple screws onto this posterior part, otherwise we would definitely buttress this, and some could say that yes, this should have been buttressed, but because we were able to get 4 screws through the plate plus this kind of oblique screw, which was one that really held it together, we decided that we don't need to go posteriorly and buttress it. So this was the follow-up as it go on. This is at about a year, and this is at 4 years follow-up. You can see how nicely the articular surface is still maintained, and he's got a good range of motion and has done quite well in a very comminuted distal tibial pylon fracture. Coming to how you decide where you should buttress these fractures, one of the ways would be to look at the fibular fracture. So the fibular fracture could be a tension failure, or it could be a compression failure, or it could be intact. Now, when you talk about a tension failure, it usually means that the whole ankle has gone into varus, as you can see here. It's a fracture which takes the ankle into varus and turns this way, and it's a tension side failure of the fibula. And here, usually you would want to put your buttress on the medial side. And remember, these are just guidelines, okay? Similarly, in a compression fracture, you can see that this has gone into valgus. And here, ideally, you would want the buttress on the fibula to be on the lateral side, okay? So here's the compression failure, and here the anterolateral plate will serve as a buttress. Of course, you have to fix the fibula as well, okay? Now, those of us who are old enough will remember the classical AO teaching in the early days, where these pylon fractures, and these were based on work by Rudy and Alcoa, were dealt with by a lateral incision for the fibula and a anteromedial incision for the tibia. So you made these 2 incisions. Your first part was to fix the fibula. Then you tried to reduce the articular surface. Then you put in bone graft into the defect in this area. And then you put on your plates onto the medial or anterior side as you felt was necessary. Okay, now, so this was the classical thing that all of us grew up with, but obviously things have changed today with the advent of understanding these fractures better with CT, and it was felt that you should keep a gap of at least 7 centimeters between these 2 incisions to avoid any sloughing of the skin there. Okay, so this would be the classical anteromedial incision that we would use, and that would be the approach to that area where you wanted to do with this combined approach of a lateral and a medial approach. However, today a lot of this approach to your fractures would depend on based on various things: the CT scan, the X-rays, and of course the identification of the key fragments, where you need to buttress it, etc., and also the soft tissue injury. Okay, so if you have a situation like this, where you can see that this is a tension type failure with where you need a medial buttress, but here you can see that there's no significant articular problem. So you would again put a spanning fixator, wait for the soft tissue to settle down, the blisters to heal, and then you would go ahead and fix the fibula, because here the fibula needs to get out to length. You fix the fibula accurately with a plate on the lateral side, and then you would deal with the medial side. So a distractor is very often useful. So you distract the joint. You can use a minimally invasive approach in these cases. Of course, one of the first step is after you make your incision, you need to identify the saphenous vein and the nerve and protect that. So that is identified. You then tunnel a route for your plate, which is in the extraperiosteal level. Okay, so it should be deep to the deep fascia, but extra periosteal. You don't want to get it go subperiosteal. You make your root. You can use various things. You can have a surfer, or you can use this kind of lever to make your root. And once you've done that, you know the length of your plate. You make your incision above, and then slide your plate in this tunnel that you made. Get it down to the correct level. And here, what you would normally do, get the position right, and then the first screw you would put is your conventional screw on the shaft, which would then help you with the indirect reduction of the shaft. So here you can see, as you pull this screw, it pulls the shaft medially and buttresses this fragment so that you get a good reduction. And eventually, that is how you fix the fracture. Here, as you can see, we used a minimally invasive approach on the medial side, got a very good reduction, and this will go on to heal well. The other sort of workhorse approach for the reduction is the anterolateral approach. And here you can use this on the anterior side, where you go between the fibula and the anterior crest of the tibia. So that's where your incision will be. You can use a smaller incision or a larger incision. And here you can see how the superficial peroneal nerve can come into your way. So you have to be very careful when you're doing your dissection in the superficial layers to identify the peroneal nerve and keep it out of your way. And then you can go in between the tendon layers. Remember, the neurovascular structure will be there. You need to avoid it. And you can decide which plane you go through to get your adequate reduction and fixation. Remember, some of these fractures could mainly involve the posterior part. So again, you need to study the X-rays and the CT scans very carefully. And you can see there's hardly any anterior injury in this. It's mostly lateral and posterior. Okay, so it will be a sort of a flexion valgus injury, plantar flexion valgus injury. And here, you really need to get your buttress plate posteriorly and laterally. So these you can do in the prone position. The fibula is reduced first, and then you can put a plate posteriorly on the fibula, on the tibia, through this approach, where you go behind the peroneus tertius, between the peroneus tertius and the flexor hallucis longus, go to the back of the tibial surface, and you can put your plate there so that it is going to give you a good buttressing of the fracture. The other approach that has been described is the anterior extensile approach. There are two ways you can do it. One is go along the crest, just lateral, sort of just medial to your tibialis anterior tendon, and then curve it towards the medial malleolus, or you can go straight down, depending on which you prefer. Both these approaches are acceptable. This is the one that is described by Assel et al. In GOT 2007, where you take it down and then curve it at about 110 degrees angle that you should have to just below the medial malleolus. And really here there are no structures. You have the tibialis anterior tendon, and then medial to it, you're down to bone. And here, this is an old fracture patient who came to us more than 6 weeks after the initial injury. The fibula had been plated elsewhere. But if you looked at the tibia, there was still a depression and an area of where the articular surface was dipunched. We don't have the CTs here, but that was apparent on the CT. So here we use the anterior extensile approach. You can see here we have to remove this anterior wall, and you can see the depression which needs to be reduced. Because this is an old case, you would bone graft it as well. And here we use these two plates, one anteromedially and one anterolaterally. And here's the screw which was fixing the articular surface after it had been brought down, and the graft on top of it. Okay, so this is the postoperative X-ray. Because this was a late case, we kept a spanning fixator on it to hold things in position. And this is the follow-up at about 1.5 years. You can see how well this has gone on to heal and is got a reasonable range of motion considering that he presented late. Now, here's another very bad injury. And you can see there's severe comminution. There was a lot of soft tissue swelling. So she was put on an external fixator first. Again, the CT scans show you significant comminution and pattern of the injury. So here we first went posterolaterally. Okay, so there we went to the back of the fibula, to the tibia. We buttressed the posterior part of the tibia with this plate. We are using very often the distal radius plates, which we mold to do our buttressing for this part. And then, of course, we needed to fix the fibula, but we also went anteromedially through this approach, where we could then reduce the medial part and the anterior part of the fracture. You can see there's a lot of comminution. You also have this die punch portion where the articular surface needs to be put back into place. And once we got a reasonable reduction, that gap you need to fill with bone graft or bone substitute. You put in your provisional K-wires once you got your reduction. Here we put an anterolateral plate and a medial plate and a posterior plate. This patient did not have a fibular fracture, so we did not have to do anything for the fibula. But this is the reduction and the fixation. We kept it on a spanning fixator for 4 weeks to protect our fixation, and then started mobilization. And you can see here's the bone substitute that has been put here, the postoperative X-ray, 6 months post-op, and this is at 16 months post-op. You can see her gait is quite normal, and she's got not a full range of motion, but a reasonable range of motion. And this is reasonably well maintained at 22 months post-op. And we've got further follow-ups, and she's still doing quite well. Now, one of the advantages of this lateral approach that I talked to you about is you can do your fibula fixation and your anterior tibial fixation with this. There was another patient with quite a significant soft tissue injury. So initial spanning fixator, the CT scans, you can see there's a posterior element to it. So once we do the reduction and the fixation of the fibula and the anterolateral plate on the tibia, we can also use the same approach. So here's the peroneus tertius. You can go behind it between the peroneus tertius and the flexor hallucis longus, get to the interosseous space between the fibula and the tibia, and then back to the posterior part of the tibia. So you can go all the way back here. You can see the posterior part of the tibia there, and also put a buttress plate at the back. So here we put a small buttress plate at the back. We just used one screw for the medial fragment. With all the other implants there, it was quite stable, and he went on to do well. So basically, in these Pilon fractures, your approach is dictated by the fracture pattern. Okay, so depending on the fracture pattern, you would do your approach. So here's an interesting fracture. You can see that the tibia is fractured and the fibular fracture is really very low. Okay, so you can really see that only on the CT scans. There was an avulsion of the ligament as well of the anterior talofibular portion. So now you can see the articular surface here. We use the lateral approach. You can see the articular surface of the distal tibia. There's more displacement that we felt, so you can get a good reduction. Put your provisional K-wire, then put your screws to fix that. Then we go on to the fibular side. Okay, so you can see here's a buttress plate on the anterolateral part. Here's one screw to fix that sort of avulsed portion from the of the anterior tibiofibular ligament, and we did a tension band wiring of the very distal part of the fibula, which was a very distal fracture. So this is how we fix this, and this is a 6-year post-op. You can see that she's doing quite well with this, with everything healed up together and a good function. So we come to outcomes, and if you look overall at the literature for the outcomes, it's still not that great. Usually the best improvement you get is in the first 6 months, although we have patients who've improved gradually over 9 months to a year, but there's some controversy as to how much improvement you can expect beyond the first 6 months. The role for definitive external fixators is reduced but is still there. And you can combine a fibular fixation with the external fixator. You can use ring fixators or hybrid fixators, or an external fixator with limited internal fixation. And we've used all of these depending on the soft tissue injury. Just a couple of examples. Here's again a pilon fracture with not so much articular displacement, although there's articular involvement. This patient also had a foot compartment syndrome, so we decompressed that. And you can see we've done some minimally invasive screw fixation, a K-wire for the fibula, and a ring to fix the pilon part of the fracture, extending, spanning the ankle. And you can see this gives you quite a stable fixation, which will do well. And if you look at the literature, there are equally good results with the spanning fixator for some of these fractures, as opposed to stage open reduction and internal fixation. Although today the generally the gold standard is towards open reduction and internal fixation with staged fixation. We also today have the suprapatellar nails, where we can do some combined fractures or very distal fractures with the suprapatellar nail, where the soft tissue problems are much less than with plates. So that's another option. Remember, compartment syndrome, although not as common in the pilon fracture as with the proximal tibial fractures, is something you need to watch out for. This was a patient who was admitted in the early hours of the morning with a lot of pain and swelling. And by the time we did a ward round at about 6 in the morning, he already had lost movement in his toes. So we took him straight to the OR with minimal investigations, no CT scans at that time. We got them later. We went in, we did decompression. You can see the kind of severe compartment swelling there was, and the kind of tight compartment sort of compression there was. You can see that's where we are cutting the deep fascia. We also had some swelling in the foot, so we extended it to include decompressing the foot on the lateral side and then across to the medial side. And then we put on a spanning fixator, and this patient got back his function of his toes. So this was treated definitively in an external fixator, but we were able to salvage function in a limb that really came with an established compartment syndrome. So one needs to look at the complications, and with open reduction and internal fixation, if you looked at the early studies with high energy fractures, there was a very high rate of complications ranging from 10 to 55%. This has been reduced significantly with the stage procedure, and you can still have problems with skin, soft tissue, infections, and osteomyelitis. The non-union rates are not that high, but in this study by Bourne et al., they had almost 25%, but another study by Sirkin et al. Using stage fixation had no non-unions in their study. Malunions are more common, and these could be extra-articular and intra-articular. And here's a big problem. We can deal with some of these with extra-articular osteotomies, but once the joint has become arthritic, then we really have very little option but to go for an arthrodesis in these cases. The complications with external fixators are not so much deep infections, but probably inadequate reduction and pin site problems are more common, and therefore malunions are more common. So in conclusion, I think one needs to remember the soft tissue injury. One needs to assess the fracture geometry. I think it's important that you familiarize yourself with all the approaches and use the appropriate approach for the particular fracture pattern that you're dealing with. And remember, soft tissue, soft tissue, soft tissue. Always remember to take care of the soft tissue. So here's a rough decision-making algorithm. So if you have a minimally displaced fracture, and we haven't talked too much about this because we are talking more about the displaced fracture, some of these can still be managed with a cast, but the moment you have articular step-off or depressions, I think you would go more towards operative treatment. If the quality of bone is poor, then again, depending on the soft tissue swelling, you would go for staged treatment initially with spanning fixator, and then for the poor quality bone, you definitely need lock plates. For the good quality bone, you can fix with conventional plates also. But today, the anatomical lock plates give you an advantage in terms of what you can fix and the direction you can fix and the stability that you can get with these. Of course, there will be a few cases where you might consider definitive external fixator depending on the amount of soft tissue injury and if there is compartment syndrome, etc., where you want to avoid using internal fixation. So I think probably the most important message is to remember that pilon fractures, especially the high energy pilon fractures, are soft tissue injuries with concomitant fractures. So you have to treat the fracture well, but most importantly, manage the soft tissue adequately so that you don't have some of the disasters that we see from time to time. Thank you very much for your patient hearing, and I'll take questions now.
Thank you so much, sir. So one thing which, while waiting for the question, so how to decide that foot is also having compartment syndrome, if there is a compartment syndrome of the leg, clinically, how to?
So I think so for the leg, you have the clinical findings as well as you can do pressure monitoring. So again, for the foot, you can do that, but it's essentially based on swelling and the tension. Okay. So the foot, so you see a lot of patients, I think, who come later with clawing of the toes. And this you can see not just in ankle fractures, but in some of the calcaneal fractures and pilon fractures, where they are left with some of the sequelae of compartment syndrome with stiffness and clawing of the toes. And that's all they might have left. It doesn't have the classical problems that you can have with the leg compartment syndrome, where you might end up with amputations, etc. Here, the problems are less severe, but can be quite debilitating in terms, because the clawing of toes can be quite a problem for these patients as well.
So,
I think it's really based on clinical findings and the amount of swelling and tension. And of course, if you don't have movement, etc., and it's just a foot injury, then or even with a pilon fracture, you can have the compartment syndrome just involving the foot and not actually involving the leg. Okay, as I showed in one case.
So, as in the lecture, sir, they have not mentioned about the arthrodesis. So I want to know the role of arthrodesis in which case it is.
So we do not do primary arthrodesis. There has been some reports in the literature of primary arthrodesis for the very bad pilon fractures, but I look at it slightly differently, because to get a good arthrodesis when you have so many fractures is more difficult. So it makes more sense to first fix the fracture, stabilize it, and then if they have problems, so if they have an arthritic ankle, then you would go for an arthrodesis. The second problem is in infections. When you have a severe infection which involves the joint, then you have to do an arthrodesis, and some of which have really bad infection, you actually end up excising a segment of the tibia, and there you may have to do a Ilizarov transport and then an arthrodesis depending on the gap that you create. Okay.
So there is one
primary
question.
Arthrodesis is something we have not done as yet. We try to avoid doing that. Our aim would be to first fix it and then deal with the arthrodesis if it needs to be required later.
So Dr. Rajan want to know if non-displaced fracture and joint congruity is maintained, do we need to go with conservative treatment? If conservative, then which one? cast or slab?
No, I think if you're treating conservatively, you would put a slab while the swelling is there and then convert it to a cast. Okay. And we have treated some of these. We have some cases also, but I haven't shown that in this. But if the displacement is minimal, sometimes where the patient may not want surgery, okay, that could be another reason where you might treat them conservatively. But certainly for minimally displaced fractures where the alignment is okay and there's no significant articular step off or depression, then certainly a conservative treatment is an option. Okay, and it's usually a cast, initially a slab till the swelling settles down, then a molded cast which you can keep them non-weight bearing for some time and then partial weight bearing after the first 3 or 4 weeks.
One more thing about that osteoporotic bone and doing orthodesis. So maybe double fixation type of thing we are doing in couple of cases when there is lot of osteoporosis with pilon fracture.
Yeah, I think that's another option where we combine internal fixation with an external fixator or add more fixation. So this happens also in the ankle where you sometimes put your fibular screws, more in ankles I would say than with tibia, than with pilon, where some of your fibular screws go across into the tibia to give you better purchase. And combining of internal fixation with an external fixator to protect your internal fixation. That is another option that we can certainly do for the very osteoporotic bone.
And so for that diabetic or vascular insufficiency, we can choose that option.
So diabetics, definitely, I think more than diabetes is the ones with neuropathy. Okay. If they have neuropathy, I think you need to look at these patients much more carefully because they will, and this is just as true with ankle fractures, is they'll totally disrupt your fixation within no time at all. Okay, because they don't feel pain, they'll put weight on it before the fracture is anywhere near healed, and then that will cause a loss of fixation because often the bones are osteoporotic as well. So the ones you need to look, especially the long-standing diabetics, you need to assess them for neuropathy and decide on your fixation based on whether they have neuropathy or not. I think for the non-complicated diabetes where there's no neuropathy, then your fixation doesn't particularly change because of diabetes per se. But neuropathic feet need a different kind of treatment.
So one question from Dr. Avinash, that what should be the post-operative rehabilitation protocol for these fractures?
So I think it's you need to try and fix them so that you can start early range of motion. Okay, so ankle movements you want to start. Weight bearing is usually delayed because the articular area, there's intra-articular involvement and impaction of the articular surface. So start mobilization, but not weight bearing. And usually you would go on to partial weight bearing at 4 to 6 weeks and then full weight bearing at about 3 months. But you want to start early range of motion of the ankle.
So one thing which we find little more difficult is what the die punch fracture, like in supination adduction injury, like when there is vertical fracture of the medial.
So now, so again, you're confusing an ankle fracture with a pilon fracture.
That one, sir, yes.
Okay.
It's a little different, but sir, because.
So there you need to look for two things. One is the fracture line, and the second is whether there is impaction of the area just lateral to the medial malleolus. Okay. So if there's impaction, you need to elevate that part before you fix your malleolus. And again, very often because it's a vertical fracture, I mean a sort of horizontal fracture line, your direction of screws have to change. Okay. And if it's a vertical fracture line, you can't put your oblique screws. You need to put your screw more transversely, and you need to buttress the fracture as well. Okay. Because if you see, some of these are a very vertical fracture line on the medial side.
So, as Arvind sir is there, so sir, any role for arthroscopy in those cases? But sir, to see the joint.
Some
How to
patient
fix-
is having associated syndesmotic injury also at the same time. One thing is that particularly in post-reduction cases, and also some is having malreduction or gap between, suppose it's anterior posterior fragment is there. Many a time Pilon is having 2-dimensional fracture or sometimes 3-dimensional fracture. And we see in the X-ray that's the fracture has reduced. But really, if you get the CT in the post-op time and you find that there is a gap, so that can be assessed with your arthroscopy part also. And also the syndesmotic injury. When post-op cases, you find everything is fine and patient is still having pain and patient start walking. So maybe that one of the possibility that you have missed the syndesmotic.
Yeah, I think the arthroscopy is gradually beginning to have a bigger role in both in the proximal tibia and distal tibia fractures. Some people even do it in high energy fractures, but by and large, I would caution against its use in high energy fractures, but certainly to assess the articular reduction, because just like in the proximal tibia, you can't visualize the entire articular surface. So with the scope, you can visualize the articular reduction much better. Okay, and even so, you can, as a visualization tool, it's definitely very important. And some people also do the reduction based on arthroscopy. So for the simpler ones, you can now do your reduction, look at its scopy with the scope, and then do minimally invasive fixation for the articular surface.
So even if there is no arthroscope, sir, so what are the means to see articular reductions? Rather than Shyam, do we have anything?
Yeah, you can look in. I showed that last case where you could look into the articular surface. There are two ways. One is you can open out the window. Okay, so just like in the proximal tibia.
That in Femino approach we have shown.
In any approach, even with the lateral approach, you can anterolateral approach, you can do it. Where if there is a window on the anterolateral side, that fragment can be rotated and you can look into the joint, or you can through the talus, the ankle joint, you can open it, distract. So here's where the distractor can be quite useful, and then you can look into the joint. So you can get a visualization, but it's difficult to visualize the entire articular surface. Okay.
So we have one question from OrthoTV side. Dr. Swastik Sipuri sir has asked to you, sir, when you do anterolateral with a posterior approach, you do it as a single stage surgery or a two-stage surgery. Any tips or trick to deal with soft tissue coverage in those cases?
Okay, so most of these are two-stage surgery in that the first stage is the external fixator. But the internal fixation is usually in one stage because you're using the same approach. Okay, it's not a posterior approach, it's a lateral approach where you can deal with the fibula, go anterior and also go posterior. Okay, so your line of incision is towards the posterior part of the fibula, along that, and then curving towards the base of the fourth metatarsal. And anteriorly, you take off the peroneus muscles, okay, the peroneus tertius over, and posteriorly, you have the other peroneum. I'm sorry, I mentioned peroneus tertius for the posterior part. The posterior part, you go between the other peroneal longus and brevis and the flexor hallucis longus, and then go on to the posterior surface of the tibia. Okay, so you can deal with both through one approach. The approach, it's actually a lateral approach, not a posterior approach. And usually, because you have only one incision, if the soft tissue has settled down, it should not be difficult to close. The other advantage is if you have difficulty in closing, because your plates are anterior and posterior, and this flap is there, the plates are not exposed. Okay, at least the tibial plates. Okay, so what you can do is, if you are worried about tension, don't do a complete closure. Put it on negative pressure wound therapy and then close later. Okay, so that's the advantage of that. So you have to always look at the tension. Usually the advantage of this is when normally you have to have two incisions, you're managing with one incision. So the closure is actually easier. Of course, if there's swelling, you have to take cognizance of the fact, otherwise you'll end up with necrosis of the flaps. So if there's tension, it's better to do a secondary closure, or you can use bootless sutures and gradually close the wound. Okay, so don't try to close it at the same time. Negative pressure therapy helps you in these situations, but the advantage of this is that you're using one incision to fix both the tibia and the fibula.
Sir,
Yeah, Dr.
Yeah.
Amir.
sir, role of MRI, sir, here.
So again, so I think the role of MRI is not so much for the displaced pilon fractures, because if you do an MRI in that stage, you're going to have a lot of difficulty in reading the details. So where the MRI is useful is for a syndesmotic injury. Okay. Now, pilon fractures, often the syndesmosis, unlike ankle injuries, the syndesmosis is not involved, nor are the medial and lateral collateral ligaments, because the bone has taken the brunt of the injury. Okay, but where you have a lot of swelling, but the fracture doesn't seem to have such a lot of injury. Okay, so you have a minimally displaced fracture and a lot of swelling. That's where the MRI comes in more useful, because you need to look at soft tissues more critically in those situations. Okay, so I think that is this thing. And the second thing is, if you have any evidence of instability after you've done your fracture, okay, then you might have to do an MRI. So today we tend to use titanium plates, so it's possible to do an MRI after the fixation if you feel it's necessary. This is of more importance for the proximal tibia than so much on the distal tibia, but it may come on later that you also need to assess the stability of the joints in terms of the ligamentous injury. You don't have ACL and PCL like you have in the knee joint. You just have the medial and lateral ligaments that you need to worry about.
So there is AITFL fragment. If in the fracture there is AITFL fragment, does we need to need syndesmotic screws, sir, there?
Okay, so if you fix that fragment properly,
The tilo fragment is.
the tilo fragment, it could be posterior, anterior also, where the syndesmosis is involved because of the fracture. Okay.
Yes.
So there, yes, you need to fix that. Usually you do not need syndesmotic screws if you fix this adequately. But if you think there is a problem with the syndesmosis, like I said, it's not as common as you do see with the ankle injuries. Okay. But if you think there's a problem, certainly the bony avulsions need to be dealt with. And if at the end of your fixation, you're worried about the syndesmosis, there is no harm in putting screws across. Okay, but usually that part of the tibia will be comminuted. Okay, in these fractures. So that part where you normally put your syndesmotic screw could be comminuted. So then it's not going to give you that hold. Okay?
Yes.
So,
So you need to look at that also carefully before putting your fixation. Yeah, Arvind, do you have anything to add in that?
So this ATFL or CFL part, that is attachment on the fibula, is the lower syndesmotic part. This ligament has nothing to do with the syndesmotic injury. Syndesmotic ligaments are a little bit higher. So that's part, if it is avulged, so you can see if you go with that approach very careful. And nowadays consensus is that everything has to be seen and palpated, and then only you put the syndesmotic screw so that your reduction will be more accurate.
So in this approach, you actually are looking at the syndesmosis in front of you.
Very
okay.
clear.
So you can actually see if there's a problem with the syndesmosis. Usually, like I said, it's an avulsion with bone rather than a tear of the ligaments of the syndesmosis in the pilon fracture as opposed to an ankle fracture.
So
that is on the
CFL injury are very rare with this.
Yeah.
One thing about the MRI was that some literature are quoting that the MRI and the CT, when in the post-op period you ask for the reduction part, the both is having almost similar accuracy in case of ankle pilon fracture. I don't know the evidence of that,
Yeah, so that's what I'm saying. I think if you
The
look at
post-op
proximal tibia, now a lot of people are routinely doing MRIs in it. We are still not doing it routinely. We do it in some cases,
Yeah.
but if you look at some of the, you're talking about total knee solutions in the proximal tibial fracture, where they, as a rule, do an MRI. The problem with MRI in the grossly displaced fractures is interpretation. Okay? So when you get all these reports of ligament injuries, and yet once you fix the fracture, there is no instability.
Yeah, mostly get settled on.
Yeah, so I think
Because
you have to
sometimes
really,
ACL spine avulsion get healed
yeah,
with good accurate fixation on the proximity.
absolutely, yeah. So I think this is still a evolving science which we'll know more about in the coming years. But at present, I would not say that a routine MRI is necessary. There are a couple of reasons for it. One is that MRI takes time, unlike a CT, which today doesn't take any time. And you can put on your fixator, deal with the fracture, and then today, as long as you use titanium plates, you can get an MRI or a CT post-reduction to assess your reduction more carefully.
So what you're talking about, that is like avulsion from fracture on fibular side. That is vague stuff, sir. Is it so, sir?
Yeah.
That one
The
on fibular.
syndesmotic avulsion from the tibial side and syndesmotic avulsion
Avulsion
from the
fibula. Okay,
Chaput and this.
vague stuff.
Yeah.
That one named fracture because that.
Yeah, but that
usually
can
last-
happen. That happens even in ankle. I think today we did a case where there was a avulsion of part of the anterior part of the syndesmotic from the fibula side.
Okay.
Okay,
Yes.
but that was an ankle, not a true pilon fracture. Okay.
So
So
one thing,
there are
sir,
some variations on this. There's another fracture where the can't remember what it's called, where the posterior part is stuck between the fragment and the fibular fragment and the syndesmosis. Okay, so those are, what is it called?
Yeah, there is a case report
Okay.
over that.
Yeah,
Yeah.
got a particular name as well. So
one is Dupuytren's fracture. Is that so?
Dupuytren's is different. Dupuytren's is ankle where you have a high fibular fracture and a medial injury, which could be a ligament or a fracture. Okay, and those always have a syndesmotic injury with it.
Yes.
Because the force, it passes like that only. Like this is the ankle, suppose. So it passes from there to there to there like this.
Yeah.
Like
So
this.
there the syndesmosis is often injured till quite a long
Most
way.
of the
And those usually need the syndesmosis to be reduced adequately and fixed.
Yes.
Okay.
All these are called as the panligamentous injury around the ankle.
Yeah.
So one thing, sir, what you explained is stressed upon is that we should place the plate above the periosteum. Another thing you have stressed upon about the angiosome during the approach. So what is the concept of angiosome, sir? Is it the same, sir?
No, totally different. So angiosomes, dermosomes, myosomes are areas where the supply of a particular part is through a particular vessel or a nerve, etc. Yeah.
So how to care for that angiosome? What you have explained during that the lateral.
So that's what you have. That's an anatomical study based on that. So
Okay.
they say your incision should be along the posterior part of the fibula rather than anterior to the fibula, because there'll be an area of skin which is then supplied from the anterior part, which will have a small bridge. So if you go along the posterior, the part that is anterior is supplied that way, and the part that's posterior to the incision is supplied separately. Okay.
So in most of the cases of proximal tibia or even the calcaneum, you are not using the bone grafts nowadays. But as in these cases, a few of the cases you have shown of using the bone graft. So how to decide, sir?
Again, it's back to the same thing, na? Where you have articular surface without any supporting subchondral bone, there you would want to support it with graft or bone substitute. So even in the proximal tibia, when you elevate your depression, if you have enough subchondral bone, then you don't need to put any graft. Okay. So the incidence of grafting has gone down even in pilon fractures. Early on, if you looked at the AO studies, they grafted it. It was like a routine. You fix the fibula, you reduce the thing, you grafted it, and then fixed it. Okay, but now we would only graft it where we feel that the articular surface needs some support. There's no subchondral bone below the articular surface. So I showed one case where we did primary grafting. The other was a old case. So that's a different situation. Okay.
So just one question, sir, in about the approach, sir, as you have shown the tension and compression fracture of the fibula, and is it, sir, what I have understood that for the tension, it should be when it is in varus, we can place
so the fibula has a tension side and a compression side.
Yes, sir.
Okay. So if it breaks on the tension side first, it will go into varus.
Yes,
so that's
sir.
the lateral side. So if that breaks, it'll go into varus, and there ideally your buttress should be medial.
Okay,
As
sir.
opposed to it when it breaks from the medial side first. So there's comminution on the lateral side. It goes into valgus. There your buttress should be more on the lateral side. So we can't go true lateral, it's anterolateral.
Okay, sir. Sir, just one related question about that one, sir. That you have used some plating for the fibula from the posterior side, and sometimes it is on the lateral side. So how to decide about that, and which one, when we can apply?
It depends. So you need to look at the forces, okay? So if it is a plantar flexion force, again, similarly, you need to buttress it posteriorly. Okay. So if the injury is just a plantar flexion injury where it's going, so there's a displacement and angulation towards the posterior side. Okay. So anterior apex angulation, there you want to put it posteriorly. Okay.
So yes, sir.
I think we're coming to the end
Yes,
of
sir.
time.
Yes.
Oh, it's already 8 o'clock, I think.
Yes.
Great. Thank you very much.
Thank you so much, sir. It was great, sir.
Sure.
Great
Thanks.
learning. Yes.
Thank you. Good night, sir.
Bye. Thanks.
Thank you, sir.
Sure.
Good night, sir.